Excellent. Good morning, everyone. Welcome to the South West London CCG governing body meeting. Welcome to committee members and also to all attendees and members of the public who might be watching on the website. Reminding people the meeting broadcast and it's being recorded, so it'll be uploaded onto the CCG website after the meeting. Members of the public are able to ask any questions live in that section at the end of the meeting, and we'll do our best to answer them as part of agenda item 11, which is questions from the public. So into the business of the meeting, we've not had any apologies received, and just to remind people that there's a declaration of interest register of members available in everyone's papers. Is there anything that isn't reflected in the register of interest, any particular conflicts of interest I need to know about for the purposes of this meeting? No? And I declare we are quorate, so we can continue with the business of the meeting. The first thing of which is to approve the minutes of the last meeting, which was 7th of July. So can we just go through those? I'll take them page by page. So if we just go through page 1 of the minutes, page 2, and just put your hand up if you've got any issues. Page 3. In fact, if you just shout, because I'm having to scroll through them on my screen, so I can't see your hand. Page 4, page 5 of the minutes, and I think that's it. So let me come back to live view. So no issues, so we're happy with the minutes. So I shall then approve those as an accurate record of the meeting. Great. So straight on to agenda item 4, which is the chair and accountable officer. I'll add that in your packs. From my perspective, the two things that are in my section of the report are, first of all, the results of the 2021 GP patient survey. And what's bridging is that in South West London we've performed really well in relation to the national average, and particularly in London as well with our CCG peers. The results of the South West London CCG patient survey are really encouraging. So I think we need to commend all our practices for the incredible work they've done at a very, very difficult time this last year, and also to the team in South West London and in each place who's been providing a huge amount of support to primary care as they've had to adapt to working in a completely different way. So congratulations to everyone on that. The second item in my section of the report is the self-assessment. So we're required to undertake an annual self-assessment as a CCG. We were assured in all the key thematic areas, which is really good. So congratulations to everyone for the work they've done in the CCG for the last year to deliver that, and particularly thank you to those who helped prepare the information to go up to NHS England and NHS Improvement so that we could be assured. Sarah, do you want to just pull out the key bits from your section of the report?
Yes, thank you, Andrew. So firstly, on blood tubes, people will have read this in the media. There has been an issue, but we are managing to ensure that the patients with the highest need can be tested in South West London. So that's just a brief update. We are continuing to develop our ICS plans, and we're holding a number of listening events with our partners to talk about how we set up our governance for our partnership, and we will be going through a process with NHS England. And just on support to refugees, I think it's important to note that Croydon actually seems to be taking the brunt of our work on refugees in South West London, and although at the time of writing this report there were 300 refugees in Croydon, we are looking at more than that now, and I know that Matthew, if there are any questions on that, can talk about that. And then finally, I just wanted to say something briefly on vaccines. I just wanted to say that we have done fantastically well in South West London on vaccines and have delivered over 2 million vaccines to date, and we are now working on the booster campaign. We are concerned that less people are coming forward for their booster, so we would encourage anybody that is contacted by the national team, because you don't come for your booster unless you're contacted, but anyone that is contacted, please do come forward for your booster. And also we are still offering what we call an evergreen offer for those that have not yet accessed a vaccine at all. You can still access your vaccine in South West London and a number of sites. And we're also working with all of our local schools across South West London to make sure that we offer all of our 12 to 15-year-olds a vaccine between now and half term. So that work is ongoing. I just want to add at the end of this my thanks to Matthew, who has taken on throughout the pandemic process the lead as a chief executive across South West London on the vaccine programme. And we've made fantastic strides in South West London and actually have achieved parts. So a little back on this work, and that's the point where plans there are in place forward for the work that needs to be done. Because I agreed to take on across South West London some other roles, such as diagnostics. So there's a lot of other work going on that Matthew is going to take on. So Tonya will continue now as SRO, but Matthew will be available, I know, should they need any chief executive input into the programme as that moves forward. And that was my update. Andrew, I didn't know if Matthew wanted to say anything on the refugees, because that has been something that's happened very recently, that we've actually taken on more in Croydon.
Thanks, Sarah. And a couple of things. Yeah, it was off. We have done it late yesterday evening, and we're waiting for final details. But yeah, we're now up to close to 900 refugees in the borough, in varying hotels. Some of those Afghan nationals who have been repatriated to the UK, others are refugees, but the total at the moment is just approaching 900, which is a not insignificant amount. Obviously, from a health perspective, we need to make sure that we are doing all the appropriate health checks, etc. We have a team in Croydon in that because of the border team who are here anyway from the Home Office, and we have a homeless health team that supports that work. They are providing that assessment process, but clearly there could be ongoing requirements from a health perspective. Not all of those refugees will necessarily stay in Croydon, but a number will, and obviously therefore there's a primary care issue here, there's a hospital issue here, and there's more general local authority issues here, housing, education, etc. So a not inconsiderable issue on top of other things. We do have good experience in this area, which is one of the reasons why I'm sure Croydon has been identified as a locale for some of this, but it is not inconsequential challenge, and important that we do it well, and we'll obviously continue to do that, but worth flagging it, I think, to colleagues. So that was the first thing to say. Obviously, have to take questions on that later. And then, Sarah, thank you for your comments on vaccines. I would say that I've enjoyed doing the most difficult piece of work that we've ever done, but I'm well blessed by the people who've actually done work. So we have a great team who are supporting it across South West London. Huge help from Tonya as my sort of joint SRO, the sort of corporate team that have overseen it, but crucially these who have actually delivered about 70% of the vaccines themselves, but also the large centres, hospital hubs, pharmacists, etc., who have all pulled together and done a fantastic job. So they're the people who've done the absolutely hard work, and they've done it brilliantly. And I'm very hopeful that will continue for boosters and, of course, flu and anything else that befalls us. We'll be vaccinating for a long time yet, I suspect. So thank you for the comment, Sarah, but really it's thanks to the team who've done the work.
Thank you, Matthew, for the update, and thanks from me as well for the work you've done on it. It really has been very successful, and the work we've done in South West London on vaccines. And I'm really glad that we're able to support the refugees as well. I don't underestimate the challenge of doing that successfully, but I think it's such a good thing that we're able to do that. So any questions for myself or Sarah or Matthew on the items we've just discussed? Pippa.
Thank you both. Really helpful report. Yes, absolutely agree with you, Andrew, about the vaccine work, and the thanks to everybody. My quick question is to you, Andrew, about the GP survey. So again, thanks to all of primary care, and it's really, really good to see the report. I wondered, do we have, because we do so well on this, because of all the great work that's going on, do we have an ambition in South West London to reduce the gap between the not so best GP survey reports, and are we supporting practices where needed?
Thanks, Pippa. Good question. Probably Mark is best placed to answer that. Shall I come to you, Mark?
Yeah, so absolutely, Pippa. The report goes down to each of the borough teams, who then identify the outliers, and there's a range of initiatives, whether it be across access or indeed quality, etc., that they then work with the practices to kind of bring them up and on an improvement plan and an action plan. So we're absolutely just assured that we do at the local level.
Perhaps we could have it reported in future what the reduction in that gap is between the top and the bottom, and how we're managing to reduce that, just so we can see how we're levelling up. It might be a measure worth thinking about.
What are we looking at in relation to that in the primary care committee, Mark and Susan? Because I'm assuming that's the level of detail that you're looking at in that forum. Is that right?
Yes, do you want me to comment? It was just obviously, and that's one indicator, a number of indicators that we look at. So the GP survey, the national GP survey, is just one indicator, and we're looking at a number of a dashboard of indicators in terms of how general practice can be supported. So yes, we can do that, and perhaps we could report it back through the primary care commissioning committee report to the governing body. Would that be helpful, Mark?
Yeah, absolutely, we can do that.
Good. That's sense. Thank you both. Any other questions? Naz.
So just on the back of Susan's comment and Susan Mark's comment around the primary care cell and the GP survey, how is that then being fed back into the boroughs, the individual boroughs themselves, so that actions can be taken? Is there a process for that?
So basically, within the primary care cell, each locality is represented, and also at the PCC, and each of the borough leads come to the PCC and present what their issues are. That performance report is then shared across each of the boroughs, and the action plan then taken to the borough leads are charged with the improvement plan. So that's kind of the mini process.
Thank you, Mark. And I mean, what I am aware of is the primary care survey is a snapshot once a year of quite a limited sample of patients. And I think it's really important that we work in the way we have been, which is looking at a range of indicators for how primary care is doing, particularly in the last year where practices have had to rapidly adapt from month to month, sometimes day to day, in terms of how they're operating. So really appreciate the work you're doing in that forum, in the primary care cell, Mark, and Susan in the primary care committee. So shall we move on to the next item on the agenda, which is there's a number of reports for us to look at. There's the workforce report, which is for noting. We've got the staff survey action plan, which is for approval. And then we've got two HR policies, so recruitment and grievance policies to approve. So I'm going to hand over to Karen, who's going to walk us through this section of the agenda.
Thank you. So the first one of those four documents is a report that we indicated that we would be able to produce when we all agreed the workforce and OD strategy a couple of meetings ago. What was to share with the governing body workforce issues and workforce trends that we could get from hard data, but as Andrew also said, we get an indication of workforce also from the staff survey. So actually bringing those two documents together, I think, is helpful. This is the first time that we've seen a workforce report here. Really interested in feedback. There is some work that we're already doing to develop the report further, including things like bringing in the workforce race equality information to see how we've progressed from this time last year. And also looking at grades across the organisation. But the report that you have in front of you today shows that actually from a workforce perspective, the number of new starters that the CCG has seen this year exceeds the number of leavers. We have short-term sickness at a significantly low level, and particularly lower than the national CCG average. Turnover is lower than when we compare ourselves to the same period this time last year, but also continues to be lower in our CCG than is seen through the CCG average nationally. And we're also making very encouraging progress on statutory and mandatory training. But it also indicates some action. So we want to have a look at sickness. Well, I think when you ever get sickness reported quite low, there is a question about whether we are reporting sickness accurately. So we want to just do some work around making sure that we do that. One of the indicators in the report is recruitment and the time it takes to recruit a member of staff. And you'll see from the report that we'd set ourselves a target of 70 days for that and average recruit to hire time, but because of two particular recruitment episodes, we've missed that in June and July, and we want to take some action with managers to make sure that we are recruiting people as quickly as we possibly can into the CCG. We obviously will continue to deliver our actions that we agreed as part of the Equality, Diversity and Inclusion Action Plan to make sure that we are a fair and just employer. And then when we move on to the staff survey, we also want to make sure that our stated ambition of making South West London a great place to work is delivered through not only looking at the stats that this report shows us, but also the feedback that staff give us in that survey. So I think that's all I was going to say. I think in summary, it's a healthy report. There's no significant workforce issues that are being indicated at the moment, but I would like to keep bringing this back and keep developing it with you so that we keep a constant focus on our people in the CCG.
Thank you, Karen. Really helpful to see it as well. And I think you're right to bring it back at a time of transition. It makes a lot of sense so that we can just keep an eye on that. Any questions from members of the governing body? Pippa, let me come to you first.
Thanks, Karen. Really good to see this. Thank you. Very, very helpful. You asked for comments, and there was just two areas that I thought, reading this and then the paper that we're going to come on to about the staff survey, I thought it would be, and again, I'm just comparing this with what I see on other boards, it'd be helpful for us to see appraisal data, so the levels of appraisal and what that looks like. And also I wondered if we could track take up of health and wellbeing offers that we are offering as a CCG. I know others, other organisations do that, just so that we can see how that's progressing. Those were a couple of things for me, but really helpful report. Thanks, Karen.
Okay.
Thanks, Pippa. Let me take comment from Bruno, Karen, and then I'll get you to respond to both those.
Yeah, I think that it's a really helpful kind of report, and I think that I hope to see that kind of thing continued in the ICS when that forms properly. My question was around the balance of males females in the workforce, because it's something I recognise from my own sector, the voluntary sector also, but does this have implications in terms of workforce in reality, and is it the kind of thing about which it would be desirable to try and do something if it's possible?
In relation to which bit, Bruno? The fact that there's the
50% underrepresentation of males in the workforce. It's round about. It looked like it was 75% females, 25.
Yeah, we are slightly above the national average. The national average for the NHS is 70% females and 30% males. We'll just need to keep an eye on that as we move forward, I think, and look to make sure that we track the recruitment part. So the piece of work that we're doing behind the scenes as well is to also look at the recruitment data, not only from a workforce race equality scheme perspective, but also from a disability and an agenda and all the protected characteristics. So we are doing some work with the CSU around looking at that data as well to see where people may fall out of elements of the recruitment process as well. But we will do some work to understand that better. But we're slightly out of the national average in relation to gender.
Okay, thank you.
And do you want me to just answer the points that Pippa made? I think they're really good suggestions. I don't think we've yet got a ready way of doing appraisals, but we are looking at our electronic workforce system to make sure that we can do that this year, Pippa. So we will bring that in. And the health and wellbeing offers, I think we can do that to a degree. Some health and wellbeing offers will be confidential in nature, but I think showing the range that we have and looking at the take up would be helpful. So I can try and bring that into future reports.
Thank you, Karen. Sarah, did you want to come in?
Yeah, I just thought, as a female leader in the NHS, I thought I ought to mention that that it's correct that 70% of the NHS workforce is women, but it's only nearly 50% that are in senior leadership roles across the NHS, and obviously we need to work to improve that together. So, and I will always flag that because I think that's an important point to make.
I think that's very true, Sarah, and I think that that's one of the other things that long term it would be helpful to understand whether that is reflected at all kinds of level in the CCG, or if this kind of work is taken on by the ICS within that, to make sure that the kind of balance of the workforce is reflected by the balance of senior management too. Karen,
did you want to come back on?
And I suppose just to say that the work that we're doing with the CSU in terms of data will then look at grades. So look at gender by grade, sexual orientation by grade, ethnicity by grade, etc. So we weren't able to do that this time, but they're working on that at the moment, and that will give us a different lens, and we can then take much better targeted action on anything that we see in relation to those things.
And I think I'd just reflect as well. I mean, I do think in our senior management team we've got a good balance, and certainly in primary care we have predominantly an increasingly female workforce, and I think that's fantastic because we get the most capable people coming through. In my own practice, the senior team now is predominantly female, and they do a fantastic job. So I wouldn't want to redress that in any way. Do you want to come in?
Thanks, Andrew. Yeah, just coming back in on Karen's comment there about the breakdown of some of the characteristics. So in terms of benchmarking, some of the responses in terms of religious beliefs, sexual orientation, have quite a high number of non-disclosed responses. I'm just wondering how we benchmark in South West London with other areas. I'm just thinking about the staff and how they feel able to sort of respond to the survey.
So we haven't done that benchmarking, it's not information that's readily available, so we'd need to go through to each of the CCGs, I think. But I think that it's an important point. There are elements within all of the data where some people have chosen not to disclose, and we need to look at why. Some people have is not available. That might be because we've got old information on people, and we should be regularly looking to make sure that we've got the most up-to-date information and allow people to renew their information. But we will have to specifically look at some of those areas. We did some work recently, particularly in bands 8 and above, to get people to classify themselves for the Workforce Race Equality Scheme. And actually, when you ask people, they do it. So I think there is an element that you'll always get an element of people that want to hold some of their information privately. But I also think that as a CCG, we need to make sure that we are regularly and routinely going through people's data that is missing to make sure that we haven't missed anything and that those people are happy to disclose. But that's a process I think we need to get into. We started it with Workforce Race Equality. We did it again when people moved from the CCG, for the 6 CCGs into one. We asked everybody to renew their information. We'll do it again when we move into the ICS, and when we'll try to do it on an annual basis, really.
Thanks, Karen. And then Vasa?
Thanks, Andrew. When we look at equality and widening participation, we need to also learn to look deeper into that. For instance, say my daughter and Patrick's daughter went to the same school, same class. So really, my daughter really is just the same advantages in life Patrick's daughter had. So in a way, we should be very careful that we don't count my daughter in as our evidence of inclusivity. That doesn't count. So we really need to look further into this. It's hard, but we need to look further and wider into this and do genuine widening participation and genuine outreach into communities who are not normally in the inner circle, and also bring them into appointment and into leadership. Patrick, I hope you don't mind me talking about our daughters.
And Vasa, just to say, we're doing some work on within the ICS. We use apprenticeships, for example, to look at areas that don't, that perhaps need some support and are not, not aware of apprenticeships, and how do we use apprenticeships to get people into employment. We're looking at a whole range of things. Earlier, weren't we, about the role that ICSs have around social and economic regeneration of areas, and we'll have a look to make sure to think about how can anchor institutes and large employers in areas make sure that they use their abilities to move people and support people into employment.
So look, that was for noting the workforce report. Should we go on to the staff survey action plan?
Yeah, so the governing body will have seen this in the first time that we brought it, when we showed the report and the areas where we felt that we needed to do work. This report just brings back the action plans that we are suggesting, recommending, address the information that people told us and the feedback that people gave us about us as an employer. And just to remind you, we participated last year. We had a really good feedback, and we had a really good response rate. We set up a task and finish group of the governing body. We looked at doing a number of things. What we didn't want to do was to set a generic action plan. What we wanted to make sure of was that where we needed to, we could identify corporate actions that everybody needed to take and that we needed to take as an organisation. But also there were some significant issues at directorate level. So each of the directors held sessions, teams, and staff have helped us build a two-layer action plan. The one that you have here is the corporate action plan, but also to answer specifically some of the issues that came up in each of the directorates, there is a directorate level action plan as well. When we gave an update to the governing body, one of the feedback was, could we just look to make sure that we weren't trying to do too much? And we have done that, and we've refined the action plan only slightly. I have to say, we haven't taken off a huge amount of actions from it, but we are now recommending this as an action plan. You have two documents. You have a summary of the national themes that arose from the survey and the action that we will take, and that tracked against those actions. And then you also have a delivery plan, so showing the governing body each quarter the action that will be delivered, and we've begun to rate that as to when it's actually already delivered. And each time that we bring it back as an update, if it's helpful, we can just share with you where we've got with that. But as we've looked at it, this is the recommended action to address the staff survey results this year.
Thank you, Karen. Really helpful. And there were a few of us who were on the working group looking at this, so it might be worth just hearing from those. Susan, I think you were on the working group, weren't you?
Yes, that was it was very helpful and very assuring to see the sort of process that went on and the level of engagement that went on with the staff, and how the sort of action plan has been pulled together. You can see from the action plan, though, it's done on a quarterly basis in terms of which ones are going to be tackled when and where. Karen, could you just remind me the bits that are in green as well as a tick? That means that's completed.
Yes.
But also, given that we're now in quarter 3, I don't know whether any of those actions you can tell us about that you've had and how we're measuring progress in each of those areas. Because obviously, I know today we're talking about the action plan. The action plan is a moving target, and we've already been working on it for some time. You've been working on it for some time. So it'd be just interesting to get some feedback on the impact we're having and how we're measuring that.
Yeah, sure. So I think the first thing to say is the greens were at the time of reporting. Obviously, we've now tipped into Q3. We'll now have to go back and have a look at all those other Q2 actions, but they were green at the time of reporting, but we'll need to keep doing that, and we will. I suppose there are a number of indicators that give us positive feedback on the action that we're taking. I think Equality, Diversity, Inclusion and Action Plan, there's a huge part in here around that. And we know that when we compare our race equality data this year to last year, we've made significant improvements. It's one of the things that I want to bring back next time. It wasn't yet ready to bring back, but we can see that certainly things like the success of applicants through the appointments process has changed quite considerably, because we actually took, we've put more diverse panels together. We've got specialists on those panels to make sure that we are making the right recruitment decisions. So we can begin absolutely to see that we are making good progress in those areas. I think the other ones probably, Susan, they are maybe a bit too soon to say, because we've only just been doing those ones. The Equality, Diversity, Inclusion ones we've been doing for longer, because we've been there for over a year now. But I will bring back, so I was talking to Melissa and others. So the workforce report that you've just seen, I think each time we should have a focus on. I think next time it will be on workforce race equality, and then the time after we can bring back parts of those, the action plan from the staff survey, and show people the difference that it's making. But at the moment, I think it's a little bit too soon. I know the other indicators, apart from workforce race equality, which is looking really positive actually since the last time.
Thank you, Karen. So let me take the questions or comments from Pippa and then Liz, and I'll get you to take them both together, Karen. So.
Thanks, Karen. So it's just building on the point that Susan's made. So again, really appreciate the work that's going on here. Really important, as we all know. On page 71, and it sort of links with what Susan was saying, you've talked about the temperature check. So, other places call them surveys, whatever. I just wanted to check, is that an anonymous survey that's going out? Because in the plan it says it's happening in Q3, Q4 through the staff surveys, which didn't sound very anonymous to me. And I wondered how we're going to do that so that we get genuine responses from people.
Thanks, Pippa. And Liz?
Yes, thanks. I just want to pick questions, and I appreciate that in a way it feels as if it's slightly more designed for clinical staff than staff who aren't in a patient-facing role. But quite a few of the scores have declined over the past 5 years, and the ones I wanted to pick up were that only 46% said they were able to give the care that they aspired to, and that's down from 59% in 2016. And 68% thought the organisation acted on patients' concerns, and that's down from 83% in 2016. So I'd be interested to have a bit more insight into what is being done to address those, and also really, I guess, how the various working groups interpreted, those responses, given that they're not mostly, I guess, directly patient-facing roles. And I couldn't quite see in the action plan how those kind of issues are being addressed. Thanks.
Thank you. So, Karen.
Okay, so thank you very much for both of those. So Pippa, the pulse checks that we have, when we use we have something now that we've purchased called Mentimeter. It's anonymous, so we can ask anybody anything at any point and get a whole range of information back, whether it's a percentages of what people thought, whether it's free text. There's a whole range of ways that we can do that. We thought that we'd probably use it in the team talk sessions that we have. It was really, really helpful, and some of the directors may want to explain this, but when we had the conversations that we did with our teams, we used Mentimeter. So we asked them to explain some of the feedback that they've given. So, for example, in my directorate, there was something around decision making, and so we couldn't understand what that meant. So we asked a range of questions using the Mentimeter tool. And actually what it did is it got to the fact that people wanted more information on recruitment decisions. So if you looked at what you originally thought, or what you might have thought when you read that, and actually when you then get the very specific feedback, it was very different, and we took a very different action. So I think we'll continue to use Mentimeter. We'll probably use it in the team talk sessions that we have, and Charlotte and I and others will think about the areas that we want to explore a bit more. And actually one of them, Liz, is the information that you've just raised. So there is, you're absolutely right, there's a deterioration in some of those scores, but actually the majority of our staff do not provide, in fact, none of our staff here provide direct patient care in their role that they perform with the CCG, but more people have an impact on patient care, obviously. So we want to use the next staff briefing session to explore with people in the way that we did previously, exactly what do they mean by that and what have they taken when they've actually given those scores. So it gives us the ability, Pippa, to target information and do that pulse check, but also get us much more detailed information about what people actually think, rather than what we assume that we take from those things. So I think, Liz, just to pick up on your part, they are written very much as a provider, but we need to understand how people are reading those and why they are scoring in the way that they are. But we'll do that for next time, and we'll do some specific work on that, and we'll bring that back and share that with you.
Thanks, Karen. And Mark, do you want to come in?
I suppose it's just to provide the board with assurance that at a directorate level, we've also used our results. So you've got the aggregate results here, but we've taken our kind of Merton and Wandsworth results for me. And actually we used Mentimeter in a team meeting to kind of really dig into not just what people meant, but also the actions that they wanted to see from that as well. So that's an ongoing piece of work. We did use Mentimeter, I think, across the organisation.
Thank you, Mark. So look, with those questions and comments, I'm going to ask the board whether we're happy to approve that action plan so that we're confident that is addressing the issues that have come up in the staff survey. I know that we had that assurance in the working group that some of us were part of, but we need to formally approve this at the governing body. So can I ask people whether they're happy to approve that? Yes? Good. Okay, so that is approved. And then, Karen, if we could go on to the two HR policies that we also need to formally approve.
I'll do these very quickly because actually there are small changes in the grievance policy to recognise that we are a single CCG, and the cover paper outlines the changes that we've made. So there isn't anything significant in the grievance procedure. We've made things clearer and we've made them more specific to the CCG, and we've agreed both of these policies with the trade unions. The recruitment policy takes into account the actions that we agreed from the Equality, Diversity and Inclusion Action Plan. So it amends it to make sure that the policy reflects the suggestions that we have put to, sorry, not suggestions, the recommendations that the governing body have made in terms of the way that we treat people, because when we had the listening events on equality, diversity and inclusion within the CCG, there was a very strong feeling from our Black and ethnic minority staff that there was a feeling of that the organisation wasn't open, transparent or fair in the way that it recruited, and we have made sure that and that people weren't given the same opportunity. So you'll see in the policy it says things like, we recruit internally, so unless there's a really extreme reason why you couldn't, then we'll make sure that every opportunity is given to our staff internally before we go external to advert, etc. So what we try to do with the recruitment policy is just to reflect that we want to take a different approach to equality, diversity and inclusion, and therefore make sure that our policies support that. And they've both been through our trade unions, we've negotiated them, they're very happy with those to recommend.
Thank you, Karen, that's really clear. So are there any questions on either of the two policies from members of the board? No? Okay. In which case, given what we've heard, I'm going to move us to formally approve them. So if we can start with the recruitment selection policy, are we collectively happy to approve that as a change to the policy? Yes, good. So that is approved. And then the grievance policy, likewise, we're happy to formally approve that. Yes, good. So that is approved too. Thank you very much, Karen. So let's go straight on then to section 6 on the agenda, which is an update on engagement around the renal proposal. So hopefully have we got James, or is it Charlotte who's doing this?
James is going to start. Then I'm going to finish.
Okay.
James, welcome.
Thank you very much. Good morning, everybody. I think most of you know me, but my name's James Blythe. I work for the ICS. I'm currently on secondment for a role working between Epsom and St Helier and St George's, but I continue to be responsible for specialised services on behalf of the ICS. And in that capacity, I've been leading the work looking at the potential changes to renal services between Epsom, St Helier and St George's. So the governing body will be aware from previous work that the proposal to consider some changes around renal services came out of our Improving Healthcare Together process, and was actually a proposal that came from the renal clinical leaders of the two services, that they thought that we should consider bringing the two services together and centralising the inpatient care for renal patients at St George's in a new unit. So we obviously have needed to make sure that we run the appropriate processes around this potential service change. We had a committees in common between South West London, Surrey Heartlands and Frimley CCGs earlier in the summer, and the outcome of that committees in common was that we would move to engagement on these proposed changes. So primarily what Charlotte and I are here to do today is just to feedback on the on that engagement exercise. I'm going to take the paper as read and just make a few points in summary. So the engagement ran from July the 27th to September the 7th. It was targeted at three main audiences. So those direct proposals and those who might have a sort of wider interest in a couple of categories. We work really hard with our clinicians and also our kidney patients associations to shape the materials, because we know that this is a relatively complex area of care, and that so therefore, given that the majority of the interested audience was actually kidney patients, it was really important that some representative groups were involved in helping us shape the materials. I'll let Charlotte give the summary on the sort of how the engagement ran and who we spoke to, but I think the overview that I would give really is that we got a good response to our engagement. 80% of the responses were from kidney patients, and 3/4 of our respondents thought these proposals were good or very good. And although it was difficult at times to explain what's a quite complex clinical case about the benefits of centralisation of inpatient care in a single unit, actually, it was registered with patients who access at the moment that there were really strong benefits from doing it, and they could see how it would lead to a better service. The issues that did come up were around travel and transport, and we are in particular having further conversations with the providers involved about how, for example, we address some of the concerns that have been raised about parking. In terms of next steps of the process, we obviously have this outcome. We're going to finalise and circulate an engagement report, and then the engagement report, along with the decision-making business case, will come back to a committees in common in November. So I'll hand over to Charlotte to talk about some of the details of the engagement.
So just the highlights really. So you've got information in your pack. So really a very comprehensive engagement plan, which, as James said, we did iterate with the Kidney Patients Association and also with some really good advice from our Community Engagement Steering Group. And I think the really important work is with those directly affected and those people who use kidney services. So we did a lot of work visiting clinics, visiting outpatient units, writing to over 3,000 kidney patients and working really closely with the Kidney Patients Association to make sure we can access those patients. We also did do wider work as well, so running 10 independent focus groups with equalities groups
and telephone interviews for those who are digitally excluded. That's really important as well. Staff, we had drop-in sessions for staff, and we had wider public meetings. So really very comprehensive and some helpful and comprehensive feedback from local people and from patients. And I suppose just quickly to say thank you to Claire Thomas, who did mastermind all of the engagement plan and the iteration of it, and actually did a lot of the face-to-face and virtual engagement herself. So I know she's listening. Just wanted to say thank you to Claire for all of that. It was really hard work, but I think some really good results.
Thank you both. Really good work and really helpful update. So shall I open it up to questions from the governing body? Bear in mind this is for information for us to discuss and note. So Pippa.
Thanks, Andrew. I just wanted to make a comment. So as the lay member for this who sat on the committee in common, I did check this with James, I did attend one of the listening events because I wanted to hear how we were engaging with the public on this. And I think we just need to thank the whole team, because I think the whole process has very comprehensive, and you can see that in the information here. And engaging, and I actually heard the real seeking out of listening to the views of kidney patients on the event that I heard. So it really was good, and you've answered my question, James. Thank you. Where we go from this, so thank you.
Thanks, Pippa. That's really helpful to hear. Bruno, can I bring you in?
Yeah, I just want to echo what Pippa was saying. I think it was a really robust and effective engagement exercise, which looked into the things that it needed to. The views from patients were got, and I think they're really critical. And I do think that we do need to be careful to try and address the kind of transport and parking issues that were identified, because that's the ultimate test which patients really care about, whether or not what they have said is actually acted upon later on. But I hope to see more engagement exercises of similar quality when this is an ICS effectively.
Thank you. Well, look, two really good bits of feedback there. Any other questions or comments from the board? No, I think it's really reassuring to hear that. So thank you to both of you, but also for the teams who've been working on it. Obviously a really good exercise. Okay, let's go straight on then to item 7 on the agenda, which is an update on children and young people's mental health from Tonya.
Thank you, Andrew. And I'll take the paper as read, so just give some highlights from the pack. So we are seeing an increased activity in CYP mental health, children and young people's mental health referrals, and in some instances that is above the pre-pandemic levels. And we have been allocated extra funding centrally to support the transformation and increasing capacity and children and young people's mental health services, and the detail of where this funding is being targeted is included on the second slide of the pack. But you can see the focus is on investing into children and young people's community and crisis services, development of the 18 to 25-year-old services, and eating disorders. But we know that funding is not enough, so we do need to transform our services as well. So we had a deep dive at the Mental Health Transformation Board on the 1st of September into children and people's mental health services, and we've agreed a number of next steps, including the implementation of the I Thrive framework in 3 of our boroughs. Merton is already working with that model, and Croydon and Wandsworth have plans that are very similar. We'll map the services we have on offer to make sure that we have parity, and if there's any gaps, plans to close them. Reviewing of our children and people's mental health services single point of access and crisis offer, and making sure that any entry into services is good, so we make sure that everyone, however they enter our services, has the same offer. And demand and capacity modelling to make sure that we plan for services to have enough capacity going forward. But we know also that one of the areas of focus we need for our children and people's mental health offer is prevention, and we have a number of prevention activities in place, and the example given in the pack is the work that we're doing around suicide prevention and self-harm. And some examples of innovation in that work is the rollout of Practice Hope with GP Practices, which is a small charity that does some really in-depth work with practice staff and how they engage and talk to young people, and we hope to be able to continue that programme going forward. And the adoption of Ripple, which is I'm not an IT person, but I understand how it works is if you can have it's a web browser that is hidden, and if someone is searching using terms such as self-harm, how do I harm myself, a signpost pops up and signposts people to support. So we're looking forward to rolling that out. In terms of crisis care, we've invested in crisis care, including our out-of-hours crisis line, which is open to anyone, not just people known to services, and an all-age crisis hub model out of South West London and St George's. One particular area where we've seen increased demand is children and people eating disorders, and we've used funding to increase support with additional eating disorder nurses and the voluntary sector support. And we're also increasing support into paediatric wards for children and people awaiting admission into specialist eating disorder beds when they're in an acute bed. Our emotional wellbeing programme continues to be rolled out through the pandemic, providing mental health support teams and implementation of support such as empowering patients, empowering communities programme, and we are going to evaluate the impact of that programme shortly, and we're about to share the outcomes of that. And finally, I think really important particularly for all our patient cohorts, but particularly for children and people, is our comms and engagement approach. And we're continually working with Charlotte and her team to look at opportunities for engaging with young people on the emotional wellbeing and preventing mental health illness. And so this work is ongoing, and we're always exploring opportunities. An example given in this pack is the campaign we run over the summer holidays to align with the publication of exam results, which I think was really, really useful. And then the final slide is just around the simple calls of action that we know are most impactful when we think about behavioural change. So just some examples of the work we're doing there. So that was my run through, Andrew. I take it the members have read the pack, so I'm happy to take any questions.
Thank you, Tonya. And I'm sure there will be a number of questions. I'm going to take Chair's privilege to go first. I mean, you know, this is a really, really tricky one, isn't it? I think we knew that coming out of the pandemic, demand would go up, and we have seen that. And you've got the tricky challenge of meeting that demand while still trying to press on with transformation and prevention programs in parallel, which is difficult to do. I mean, certainly back in primary care, my colleagues tell me this is one of the biggest issues they're having to grapple with. And I guess I'm particularly interested in the demand and capacity work, because I think we have to plough on with transforming services, but there is a problem right now, isn't there, in terms of demand for services and waiting lists and how much capacity we can put in. And I guess I'd just be interested to know how well at the moment we're matching capacity with demand, and what the process is going forward for kind of checking that on a frequent basis, and what are the options for putting in extra capacity if that's what we need to do. So that's my question, but let's take a range of comments, and you can maybe come back on them all together, Tonya, because there'll probably be some themes emerging. So Susan, shall I come to you?
I'm just in awe and wonder of Charlotte and you and all the rest of them in terms of that engagement, but it's really what we can learn from the process that you're putting in place, engaging with these young people, because it seems to be quite integral in the way that you're designing and delivering the service, because you've got to reach out to these people, these young people in lots of different ways. And I hope we can just see some case studies of this and how we might use that to learn in other clinical areas that we might be working with. And as we move into the ICS, I think this is a good example, isn't it, of where we're working across boundaries as well with health and care and schools. And I just think it would be good to showcase the work that you're doing. And congratulations, really. I just think it was an impact. You say you're doing some work on the impact of the new models of service. It'd be good to have that feedback later in terms of what impact it's been having, really.
Thanks, Susan. And Liz, can I come to you?
Thanks. My first question, I guess, builds on Andrew's question about demand and capacity, and it's how we have a sense of what's happening at the borough level in relation to that, and also how that then is reflected in waiting times at borough level to have some slightly more granular data on that. And my other question is in relating to the pioneering work that has been done in schools in southwest London, and it's great that 44% of the schools now have that kind of resilience building, but we were wondering what about the other nearly 56% of the schools, what arrangements are in place for them, and also a bit of a better sense of whether that 44% is equally spread across the boroughs or whether it's clustered in particular boroughs, and therefore whether it's higher than 56% in some of the boroughs because it's not evenly spread. So a sense of that. Thanks.
Okay, so thank you, Liz. Really good questions. And so, Tonya, over to you. And if you want help answering the final bit of Liz's question, I'm happy to chip in.
Okay, I'll start, and I know others will want to contribute. So, taking Andrew's point about matching capacity and demand, absolutely, it's a really tricky thing, but we continually look, because what we want is to prevent people needing services, isn't it? So actually, so whilst we would continue to invest in mental health services, and when I talk about mental health services, talking level 2, level 3, secondary care, and that kind of provision, we also need to focus on making sure people or services that prevent people or young people needing that kind of level of specialism. So there is a real fine balance there, I think, around making sure we have the right capacity in the specialist services, but also don't lose sight on the prevention, early intervention services that we need to put in place. So we continue. I mean, I would say this is a hot topic which we continually review, and with many services, often it comes not just to the funding, it's actually the workforce to be able to meet the demand. So how do we do some work around triage earlier on in the pathway, that we make sure people are signposted not always to medical services, so the voluntary sector and other services become very key in that. So I think it's a combination of doing the actual command capacity and demand work, but also looking at all those opportunities we have as well in making sure people access support earlier, even if it's we've talked about across South London about a virtual waiting room. So sometimes the issue is not necessarily always waiting for the assessment, but the ongoing treatment. So there's different things that we are doing to make sure that we have capacity across the whole pathway and make sure that children and young people are supported in the right way. And that's not always children and young people's mental health services provided by the Mental Health Trust. So we need to continue to look at that. I would absolutely, and Charlotte may want to talk about the impact of the comms and engagement, but it is really important. And it's, I think one of the things that I would reflect on, there isn't going to be one thing we can pinpoint and say that was the most successful thing that we did, because people react to messaging and offers in different ways. So I think it's the combination of our offer. But Charlotte may want to say a little bit more about the comms and engagement piece. I don't know. Do you want to say something now, Charlotte, or should we wait till the end?
Shall I just very quickly, because I think Susan's point was interesting about what we learned. So very quickly, the two we learned doing our comms and engagement with young people is, first of all, we have to ask young people what works for them. So in terms of visuals, in terms of messaging around what is going to help them seek the right information and support for them. So doing a lot of work in school with focus groups, testing our materials, testing our messaging has been really important. And the second thing that we've learned is just I suppose it sounds obvious really, but just the value of going through schools to get young people to seek support. So we've done a lot of work on social media, because people think that's where our young people are, but actually young people in our area in South West London still do listen to their head teachers, they listen to their peer group at school, so the work in schools has been particularly important.
Thank you, Charlotte. And then finally, I know, Andrew, you'll probably want to expand on this, on the mental health support teams in schools. So the ambition in the Green Paper was actually 44% coverage. So the funding was available to achieve that, and we would have achieved that by January 22. And how we worked with clusters of schools, and we try to focus our resource in those areas of highest need, and with schools who want to really work with us on the programme. So it's not equal across the boroughs, but how we're trying to bridge the gap is looking how we can use our existing offers, particularly example in Croydon, where we have the children wellbeing practitioners, and how they can be part of the programme, work into schools as well. So whilst the emotional wellbeing programme has that dedicated resource, we will be looking at how we can use our existing resource and transformation plans to make sure that we have as good coverage as we can in schools, and that will be part of our Thrive programme as well.
Thanks, Tonya. I can't help myself but say something on that as well. I think, Liz, it's probably worth just as well flagging up the difference between our overarching programme with schools, which is about a whole school approach, versus the mental health support teams that there is specific funding come down to deliver. So what we set out to do at the beginning was to engage with schools to get them to change their ethos and culture in the school, to provide support for members of staff, and to I guess get schools to engage with this and take it seriously. And there's a whole range of different interventions that schools can deliver. One small part of that is actually putting a mental health support team in the school where they can deliver targeted interventions. But any school can adopt a whole school approach regardless of whether they have a mental health support team or not. But as Tonya says, a lot of it is dependent on engagement in the school and how much they want to do it, because even if you put a mental health support team in the school, it will only be effective if there's real commitment in the school to change the way they work and deal with mental health, and that requires strong leadership and real dedication to make it successful. So I think what we have chosen to do is work with schools who want to work with us, because we know that the resource will then be more effective. What we did do in the subsequent wave, so I think the very first wave was with those who were most keen. What we did for subsequent waves was we worked with authorities to look at the need that I'm trying to encourage schools that were located either in areas of need or had kind of school populations with particular characteristics where we knew there was great need, and we worked hard with local authority colleagues to try and encourage those schools to come forward to be part of the subsequent clusters of schools. So I think the work that's gone on has done everything that we can to increase, not just increase coverage, but also to make sure that we're dealing with the schools that need the most support. Shall I come on to some of the other hands? So Dagmar and then Patrick.
Yeah, hi. Thanks very much, Tonya. And again, I'll start with saying a big thank you. I think there is absolutely fantastic work that has been going on. So we sometimes forget because there's so much more to do. I've got 3 points. One is that in particular working with local authority on the slightly lower need preventative agenda, quite a lot of consideration going on into social prescribing for children and young people. And I would be keen to make sure, Tonya, that all the different efforts that are being considered locally, that we make sure that it connects into the whole picture. I think there is a lot of learning from what worked in adults, but there's also new and different things to be considered for children. So that was the first. The second one is a little bit of a note to self, because we had a bit of a wake-up call about the importance how to reframe healthy weight and obesity, because we've really through the pandemic seen quite a toxic combination of increasing mental health distress, often linked to body image, with a subsequent increase in disordered eating and then culminating in eating disorders. So the link between mental health and food really important, and on the background of increasing food poverty. And all of that particularly bundled in the least well off. So that is quite a complex mixture of factors. And so our rather, what I now in retrospect think, naive approach of, pushing the childhood and young people obesity agenda, there is so much stigma involved. I think we all have to somehow rethink it much more as a bundle, and the importance of well-being for all of that. And then finally, just in sharing a little bit, we've been working with schools through COVID in a completely new way. So we've got infection prevention control teams now in each of the schools, and it is a completely new relationship that we've managed to broker. And what we're now doing, particularly on infection prevention control, we are hoping that we are upskilling schools again to think much broader. So what Andrew mentioned in terms of whole school approach. So remembering the relationships that we've now brokered in local authorities with schools are fantastic springboard to hook other things. So again, I'm very keen to work very closely with you lot. And if we think where we could deliver services, bringing services to people, for young people in particular, one of the trickiest bit is if they have to miss lots of schools because they have appointments. So could some of those services be provided a little bit more fitting into the lives of young people? So a bit of a mixture. Thank you for giving me the opportunity.
Thank you, Dagmar. Really helpful reflections and input. Patrick, can I come to you?
Thanks, Andrew. So really just reflecting on sort of social determinants of health. So there's a natural link here with the Health Watch Richmond report on children and young people's mental health. And the clear message from that was really that pressure performance in schools was identified by the young people as their biggest stressor. And that obviously has implications for the new responsibilities in terms of social determinants of health. There's this sort of cultural shift that probably needs to happen, isn't there? Which points to a need really to double down on the whole school approach, really. So it was just to reflect that in the conversation too.
Thanks, Patrick. So look, there's been some really helpful reflections and input there. Tonya, did you want to come back on any of that?
No, absolutely, really helpful. And I think some of the point Dagmar raised around, particularly around the prevention piece, and that I think your bit around the disordered eating and how we reframe that conversation is going to be really important. So what I was thinking is, as people are talking is about, we're doing the work in the Mental Health Transformation Board across South West London with many partners that make sure that we have that prevention focus. And Dagmar, I will come and talk to your Directors of Public Health to make sure you and the rest of the gang sure that we get that right, because I think there is some real opportunities, and I'm very passionate that we don't just keep talking about CAM services, that we talk about children and people's mental health and emotional well-being, and that actually what we should be doing for our young people is making sure where at all possible we prevent mental illness. So yeah, I think that focus is really important. So I'll come out and talk to you, Dagmar.
Thanks, Tonya. And that's why it's so good to have a Director of Public Health on the CCG governing body. Right. So that report was for noting, and I mean, Tonya, the overwhelming feedback is really good work, recognised as a massive challenge. It sounds really comprehensive what's being done. So let's go straight on to improving healthcare together. James, you've got, I think, two elements for us. One is just updating us on the King's Fund report, and the second is a refreshed set of recommendations that came out of the decision-making business case.
Yeah. So I'll take the report as read, but as you say, there's two parts to this. The first gives you an update, which we're overseeing through the joint oversight committee that we work through with Surrey, which just updates you on where we're at with the actions that came out of the consultation process, and we will continue to bring that through to future meetings. The other thing is the King's Fund report, which we commissioned as a result of the consultation around the impact of that on health inequalities in Merton and Sutton. And you can see there that it's a pretty comprehensive report. There's no, in their view, exacerbation of those issues, but there are some recommendations and we will need to pick those up. So we will pick those up in two areas. One, we'll add them into the future sort of pack that we're working with the trust on, and the other thing we will do is make sure they're picked up within the wider piece of health inequalities work that comes out through the local health and care plans on those. So just to reassure people that those will be picked up through those two routes. The other bit, just to reassure people, is that we will hand effectively through the transition this responsibility through to the ICB. So as the business case and the programme develops, it will be the ICB will sort of hold that overview of an oversight of this ongoing work. So that will continue. The King's Fund report, as I say, is there. I think I'll just hand over to Sarah, because I know Sarah's been having one or two conversations that I think she'd like to just update the governing body on. So Sarah, if I can hand over you just to update your conversations.
Thank you. So if you remember, actually the additional health inequalities report came out of a discussion where the Mayor's Office were asking for some further work to be done. So I have spoken to the Mayor's Office since we received this report, just to check out if they have any views on the report. And what they're keen on is that we start to pick up some of the actions through the local health and care plans, which we are happy to do. So I have spoken to Mark about how we take forward the work, but particularly the Mayor's Office have a number of areas that they're interested in, which I'll just highlight to you. One is around making sure that as we start to take forward our local health and care plans, we're looking at data that is lower than just borough level, but actually goes into the detail of those local communities, which I think would be our intent, particularly as we work through the JSNAs with local authorities, and making sure we have got the right level of detail to make sure that we are actioning any local work in the right areas. The second area is around the Wilson and the development of the health and wellbeing hub, and I'm pleased to be able to say that actually I think the funding now is agreed for that for that project, and actually now the work is going on to take that work forwards, and I'm sure Mark Crillman would be happy to answer any questions on that. The other area was around anchor institutions, because Epsom St Helier previously, I think, committed to ensuring that Epsom and St Helier Trust sites were part of the anchor institution work that will be going on across the NHS, and I was happy to confirm that we would raise that with the trusts, but actually I'm sure that they want to continue that work, so I'm not concerned about that. And another area is around ethnic disparities, and making sure that through the work that we do through the local health and care plans, that we make sure we pick up any areas where we have ethnic disparities that may have an impact on people's health, and we of course were happy to commit to that. And finally, that it was brought up in the King's Fund report that obesity and diabetes are picked up as the ongoing health and care plans, and again we are happy to commit to that. What I've also said to the Mayor's Office is that we would be happy to meet with them in 3 or 4 months' time to tell them how we're progressing with those plans, and I have raised that with Mark to say would the Merton and Sutton groups be happy to go along to that meeting to talk to the Mayor's Office, and they are. So that I just wanted to update on that. I think those are very reasonable requests. I think we can do that through the work that we're doing locally. Thank you.
Thank you, Sarah and James. So let me open it up to questions. I'm gonna go first. Well, I guess more an observation than question on the King's Fund report. I know it was looking across Merton and Sutton, but I thought it just kind of validated the approach that Merton and Sutton have taken already in their local health and care plans, in terms of huge amount of action needed on health inequalities, but the sort of things that I know people are already focusing on are exactly those that are flagged up in the King's Fund report. And I think it's really important that that we continue to support local places to deliver on that. The second bit was, I'm really pleased to hear about the progress on the Wilson. As you know, as former Merton CCG chair, it's been something we've been trying to push on for a long time and really deliver for the people of East Merton. So I just think it's really welcome. I think it's right that it's picked up in the report, and I think it's really welcome to hear that progress is now going on. And Mark, if you've got any more of an update on where that's at, it would be really good to hear.
Shall I do that now, Andrew? So just to build on Sarah's comments, particularly about the Merton Health and Care Plan, and hopefully Dagmar's still on the line, is that we are using, the JSNA information and the data there to really dig down into our areas and our populations across Merton. I think in terms of the Mitcham Health and Wellbeing Hub, as Sarah said, we've had the funding indicatively agreed by Property Services, and we have moved forward now into this re-establishing the programme board that met last week. Two things it's focusing on: how do we really build on the community engagement that has already been done and take what we've already heard and build that into the process going forward? And then secondly, just around our due diligence. So as we move to a business case, we do have to do an options appraisal, and just to be really clear that the NHS, the Wilson is still the preferred option for the NHS, but as part of the due diligence, we do have to look at other options as well.
Thank you, Mark. Really helpful. So any other questions or comments? The report and the recommendations are for noting. Good. So are we happy to note that then? No further questions. Excellent. Thank you very much, James. So I'm going to move us on then to the next section, which is the reports and various committees. So we're starting with finance, and we'll have the finance report from James, and then just hear the summary from the finance committee that David has helped put together.
Okay, thank you. So the finance report for month 5 you've got in front of you, all pretty stable at the moment. So we're on course to hit break even at month 6, which is the end of H1, as we've now divide years into 2. The main pressure we've got is CHC. It's sort of starting to settle down in one or two areas, still concerns in others, and we're working with Gloria around how we just make sure that we've got control of that, and we're working through that, but that is a risk as we head into H2. In terms of H2, we do have our envelopes now for H2. They're based on the same sort of structure as H1, so it's all the same sort of issues that you would have seen before, and we'll take this through in detail to Finance Committee at the end of this month. It is more challenging in H2 because they are starting to reintroduce now the concept of efficiencies and savings. So we have across the whole system the responsibility to deliver a 0.82 cost efficiency, which we'll work through with boroughs and teams on the CCG side. We've also starting to see the COVID allocation that we've been given is starting to reduce, and that's reducing by 7% in H2, and we're also starting to see what they now call, another acronym for people to get used to, the financial improvement trajectory, which is starting to bring down some of the additional support that was put in ahead of the pandemic. So again, that's about another 1% across the provider arm. So we're still in a position where we've got a lot more money than we would have expected under normal circumstances, but we are starting to see that tighten, and I would expect that to accelerate quite significantly as we move into the next couple of years. There is, however, some money set aside around capacity for urgent care, which Jonathan and I will pick up through the planning route, and also there is another 2 stages of elective recovery funds. So there is one that is based on activity levels as before we had in H1, albeit at the more challenging end of the threshold. as you would expect, and there are also some specific bids for capital which we're currently working through with our provider colleagues and within places, which is about 700 million nationally. So we're working through that over the next week. So while there are some monies coming down on one side, there are some monies coming up in the other way. The key message, I think, as we move into H2 and into next year is I think this will accelerate. We will get more money for things like recovery, I expect, but we will start to see some of that COVID and financial support start to come down. So as a system, as a CCG, what we really need to start focusing on are our exit run rate and looking at how we bring that down as we exit into next year into a level that's going to be manageable. Not sure when we'll find out what next year's finances look like. They're currently going through the comprehensive spending review, but we have been assured by the National Finance Director that we will get some long-term sort of projections, which would be which are welcome after we've been working with sort of 6 months sort of projections, quite understandably for that. So that's my sort of summary on where we are. Happy to take any questions or take questions after David's added anything from the Finance Committee on.
Thank you, James. That's really helpful. Let's go straight on just to hear from David. We've got the notes from 2 finance committees, one in July and one in August. So that's set out in the paper. I don't know, David, if there's anything further you want to say than what is contained in the report.
No, thank you, Andrew. Just a couple of comments, if I may. We also had another meeting last week. So the Finance Committee is meeting every month now, reviewing obviously the CCG's financial position, the position for the overall system, and also there's been a number of business cases and tender waivers that we've been going through. I just want to add to what James has said about financial risk, because if you look at the slides in the financial report, we've actually shown, I think it's the one which is the CCG scorecard, and it shows financial risk as green. The point I want just to reiterate what James has said, that relates to the first 6 months, and effectively, as James has said, we've been able to balance off the first 6 months. But when you look at the second part of this year and also into next year, that's when you see the financial risk growing, and it's partly around continuing healthcare, which we are concerned about. A lot of good work going on to get to the bottom of that, but also the money is getting tighter. So I think the big challenge is over the second 6 months, being able to balance and getting ourselves into a good position for next year. But I mean, the Finance Committee is on top of that. We're going through all the figures as you would expect each month, and giving that can give the level of assurance to the board that that we're on top of all of this as well as we can be. Okay, thank you.
Thank you, David. That's really helpful. So, look, any questions or comments on that? Karen, your hand went up and down. Was that no? Any questions? Okay, it's clear. I mean, I think you both covered it really succinctly, but also reassuringly, and we've had that to look at. So I will take those 2 as noted. Should we go straight on then to the Audit Committee? So we've got a sorry, I'm just scrolling through my papers on a different screen. So we got the note from the Audit Committee in September.
Yeah.
Paul.
So the Audit Committee was held mid-September. A couple of routine elements around the policy updates, the scheme of delegation, the anti-fraud policies were updated and approved. With the insurance framework, we went through that in a bit more detail, and I think Ben, you're covering that later, so I think I'll ask Ben just to talk through that in more detail. The other key report, the external audit report, this was just a final summary of the financial outcomes for 2021 and already been to governing body, so this was just a final review. And then in the internal audit report, Chair, there were a number of update reports that were shared and the risk management, and then finally primary care commissioning. And you can see the levels of assurance that were given to each of those, and they came out with a number of management actions which have been followed upon as we speak. I think the final item, just to note, is the systems update conversation we had. Obviously, just going into that meeting in mid-September, we had just received more guidance from NHS England around the transition to the new arrangements. So obviously one of the key things is understanding what that transition approach is, what the due diligence. Obviously, with committee some gaps now for the audit committee, the oversight committee, which was discussed earlier, which myself and David are members of, is welcome to ensure that we've got visibility of that process over the next few months. So that was basically it, Chair. I'm happy to take any questions.
Thank you, Paul. Really helpful. So any questions on audit? No? Okay. So I will take that as noted. Thank you very much, Paul. So we'll go on now to performance. So we're going to have a look at the performance report, and then we will hear from the Quality Performance and Oversight Committee. So Jonathan, over to you.
Thanks very much, Andrew. So the report in your papers covers July and August of this year, when many of the COVID isolation rules following close contacts were still in place, when we were all dealing with the subsequent pandemic, as it was described, and also a period when that led to quite high levels of leave, as well as annual leave, obviously through the August period. So it's quite a challenging time, I think, for the NHS, both locally and nationally. We particularly saw that pressure around A&E challenges, where it felt more like winter pressures than the summer pressures we're familiar with. But we rallied very well as a system to address those, and an example of that will be the mutual aid on workforce that took place between St George's, sharing their emergency department consultant support with Kingston Hospital to ensure that we provided timely access and safe services through some very challenging times with workforce. The paper also notes the ongoing one-on-one performance challenges that members of the board will be familiar with, and we continue to work with Vocare to improve that performance as is set out in the paper. And we're also working with the London Ambulance Service as a resilience partner through this period to handle some of the calls, to give us a greater confidence that we'll be able to manage the challenges that the winter period will inevitably bring. Turning to elective care, the trusts have, I think, done a good job of recovering elective activity in outpatient diagnostics and elective care more generally, given the wide array of pressures I've just been talking about. There is a continued growth in the overall number of patients waiting, as can be seen in the deck. Despite those efforts, and often for very good reasons, more people are coming forward for treatment. So the ongoing pressure to keep up pace and delivery around elective care remains very strong. Overall, we remain the top performing part of London in terms of the long waiters being treated in a timely way. And of course, there's always more to do there to further reduce the number of long waiters. But we remain in a strong position as is set out in the deck. And the deck also talks about elective recovery in a little bit more detail than normal, as was requested a previous meeting. On cancer performance, we are seeing roughly a quarter more patients coming forward for treatment down cancer pathways than previously. And that's obviously good news, because we want to ensure the timely treatment at an early stage of diagnosis of more patients. But it does place place pressures on the system, and you can see some of those beginning to come through in terms of 2-week waits from GP referrals to first treatment times, and indeed in terms of the overall pathway to treatment within 62 days too. But again, it remains the best performing part of London in terms of performance on cancer. And on mental health care, we continue to deliver very well on access to psychological therapies, making good progress on learning disability health checks can also be seen in the pack, and that's really heartening to see. And also with the opening of the mental health assessment unit at Croydon, seeing a reduction in mental health breaches at that trust, which I know we've also talked about here in the past. So that's a brief summary, Andrew, of where we are at this point in time. So very challenging. I think we're all very familiar with that, but also working very well together to try and deliver on what we need to achieve through the coming months. And then I'm happy to either take questions now or wait until after Pip has provided an overview from the relevant committee.
Well, let's store the questions, because it might be some of those questions are answered in the report from the committee that's been looking at this in some detail. So let's just hear from Pippa a summary of what the committee's been up to, and then we'll take all the questions together. So Pippa, do you want to come in?
Okay, thanks, Andrew. So a couple of things I'll just highlight. Hopefully everyone's had a chance to look at the report. So to follow up from Jonathan, we were actually looking, because we met in August, at month 2 performance data. So you here have seen a more up-to-date set of data. That's just the way the sequencing of the reports go. We specifically had asked for some information and assurance around echocardiograms, and you'll see in the report that good progress has been made on this, and we got assurance on improvements around access for that. There was a theme on the top of the second page. There was a theme that came out in many of the areas, and Jonathan referred to it in the success that we had in working across South West London. So 2 areas here. Improvements have been made. It's often when systems have been put in place that work across providers, but the other was around workforce risks, and I know the governing body here have approved a workforce strategy in the past, and I think we're going to be getting that, because they're longer term issues to look at. The day-to-day workforce issues are mitigated, but the longer term risk that I think we need to keep our sights on as well. We also got an update on brain, and you can see there, as you'll see, the report stopped initially in the pandemic. There is a recovery plan in place to try and get us back up to the levels that we need to be at. Progress is being made, it's improving, and at the moment the plans are that we will fully have recovered up to the national timings by March of next year. Again, you'll see in there that workforce capacity and staffing is a key focus that the teams are having to look at to deliver that, and recruitment of radiographers. But there is a number of actions in place. We had input from both the leads from St George's and NHSC coming to give us that assurance. And we also got assurance around uptake, and were they measuring who was actually uptaking that screening service across borough, and they were. You'll see we had an update on the waiting times for children and young people with neuro development needs around ADHD and ASD. Again, this is ongoing work. There's some funding that's been put into this, a number of waiting list initiatives, and progress is being made, and it's work in progress. The children and young people suicide prevention strategy reviewed, and much of that is linked to the update we've already had from Tonya. And finally, I'll just say we received, because of the time of year, some annual reports. You can see the areas that we looked at. QPOP do have their sights on these areas regularly as we go through, but it was very helpful to see the annual review. The committee thanked all of the staff across South West London for their focus on these really critically important areas during the past very challenging year, and I'm happy to take any questions.
Thank you, Pippa. Really, really helpful overview of what you've been up to. So let's take questions for both in relation to the performance portions that might relate to the committee itself. So Patrick, do you want to come in?
Thanks, Andrew. So my comment really reflects on Pippa's comment there about workforce. So it's a really, really positive sign that we were able to get mutual aid up and running at ECHO and but we also need to look at the longer term resilience there. So continuity in clinical leadership is absolutely crucial for at place level to try to have that consistent service. And I think we are going to need to look through the acute provider collaborative to ensure that that there is that continuity leadership and potentially consultants working across different sites to enable us to have that continuity leadership. We brought it up in the clinical leadership group, and it does have the support of certainly two of the MDs there, but it is going to be a different way of working, because I've now lived through 2 episodes in 10 years of a significant loss of clinical leadership around ED in our local hospital, which just stymies the developmental work that we're trying to do as a whole system.
Thanks, Patrick. So let me say something first, just on continuity of clinical leadership, and then I'll bring Karen in, who probably wants to say something around the workforce issue. So I guess just to reassure you, Patrick, in terms of a lot of the work around planned care, particularly around those most challenged specialties, is being overseen and led through the clinical networks that we've set up. So myself and James Marsh are in the process of meeting with the clinical leads of all the networks. And what I would say is there's massive commitment to continue working across organisations. I mean, those networks have really embraced that approach, and they are looking at the list of patients as a single kind of patient waiting list across South West London and moving patients around to where there's shorter waiting times. I cannot see that approach changing because it's been so successful in the last year. So I'm confident that will continue. And also the overwhelming feedback from those reviews is the benefit of having both primary care and secondary care leadership together, and the ability then to influence the whole care pathway and the impact that has on the number of patients entering the waiting list. So there just seems such a strong commitment to that, and that comes from the acute provider collaborative and from those clinicians involved. So I think we're all committed to continuing to see that go forward. If you remember as well, we've got clinical leadership in place around things like urgent care and A&E, and those clinical leaders, I'm sure, are going to continue in those roles. So I think you'll get continuity there. In terms of place-based leadership continuity, I can't speak about individual boroughs, but I think the challenge is to demonstrate the effectiveness of what we're doing, and then regardless of structural changes, we all want to see things continue to be effective. So I think that's the best guarantee we can give. Karen, can I bring you in?
So I was just going to mention 2 things about the acute collaborative and workforce, Patrick. So there is a specific review of emergency department workforce and how do we move that forward. So that's beginning. And then secondly, just as an ongoing responsibility, the guidance is very clear about provider collaboratives using their size and their ability to provide mutual aid, of which workforce will be one. But one of the important things I'll be looking at is workforce within that part of the system as well. So just wanted to assure you that the emergency department and looking at the issues there at the moment is going to be a programme that we work on, but actually there's an ongoing responsibility for the acute provider collaborative to do that as well.
Thanks, Karen. So question from Bruno, can I bring you in?
Yeah, my question is for Jonathan. It's around the urgent and emergency care. You very clearly reflected the kind of pressures which are reflected into those figures, and I was particularly struck by the 4-hour wait indicator. Is there a sense that it's likely that those pressures are moderating and that therefore performance will be improving?
Do you want me to answer that now, Andrew?
Why don't we hold that, and I will just hear from Matthew and Vasa as well, because it may be they were coming in on the previous one. So hold that question from Bruno. Matthew?
You could see, you well judged, Andrew, because I was going to come back and just provide a little bit of a reflection on the collaboratives point that has just been discussed. Obviously, I sit with, as a number of us do, many hats, one of which is obviously as a provider, chief exec in the collaborative. And I think what I'd say is, in answer directly to Patrick's question, is there a sense that we're in this for my reading of the question, Patrick, is there a commitment to doing collaborative working on a long-term basis to address long-term issues? And the short answer is yes, and I think there's good examples of it being done over the recent period, and indeed that goes back some time, and we know that we are better on some of these initiatives as a collective. That's not true of every single thing, because there is a time received place as well, and some things are for individual organisations or for places to do, but there are elements where the benefits of collaboration with the key providers is paramount, and we've demonstrated that with ECHO and with emergency department cover very recently. The elective workload, the existence of Swelliok, which is a provider collaborative piece, the QMH site now, and the Croydon Elective Centre. Those are located in particular places, but they are collaborative ventures in many ways, and certainly have been accessed by patients of the piece. So I think there's good experience and a underlying culture of collaboration, and certainly in all the discussions I've been part of, the desire and intent is indeed to build on that, but make sure that we, a bit like everything on integration, that we focus only on the bits where collaborative approach is most valuable and will give us most benefit. There is a slight risk of saying, well, we have to collaborate on absolutely everything, and if you do that, you end up actually undermining individual organisations and stopping them taking responsibility and getting on and doing work that they should be doing themselves. So it's that balance to strike. I think South West London and the APC has demonstrated that pretty well over a period, and we're absolutely committed to continuing it. So hopefully that's helpful, Patrick, by way of an answer to your question.
Thanks, Matthew. And let me bring Vasa in.
Thanks, Andrew. It's usual that pressure in the system, wherever it is, usually manifests itself in urgent and emergency care. And if you want to help out the pressures in urgent emergency care, we have to address the pressures in the rest of the system. Otherwise, we never make any progress, and we focus to now going into collaboration in the rest of the system in some from planned care perspective. Is there any appetite to increase the number of joint appointments across hospitals? Because one of the easiest ways of making networks function better, if consultants are not loyal to one institution, but they have a broader view of working across institutions, it also helps recruitment of consultants into the system, because they are so much short in supply that if you have joint appointments with some academic component, with a teaching or research component, you can get the best resources learned. I think we should pursue that. I just want to know whether there's an appetite to input from our health system.
So why don't I get Matthew to give an immediate answer to that, and then Jonathan, you, having reflected on Bruno's question, can come back on that.
Yeah, I mean, again, I think there is some areas where there is interest in that, Vasa. We certainly talked about it some time ago to try to create joint appointments where you get people sort of getting the best of both worlds. I think that is, for some people, potentially very attractive. Interestingly, not for everybody, because some people particularly choose to work, talking about consultants, particularly choose to work in a DGH. Others particularly choose to work in a teaching hospital, and getting them to do both for some people wouldn't necessarily be a positive in terms of recruitment and retention. There are others, clearly, where that isn't the case, where there is this joint approach because it makes sense for their specialty of work. Cardiology is a classic example, Vasa, where that is done pretty extensively already. We've looked at it for emergency department consultants. There is some interest, having a bit of major trauma input and also DGH EDs. But I say, back to my previous points, that's not universally the sort of preference of people I've spoken to. So, it has to be part of options that we've got, Vasa, to help with consultant recruitment. It wouldn't be something I'd say is a must-do for every single new appointment, but where appropriate and where there's enthusiasm and where it could help, I certainly know that from a set of acute providers, we would definitely be up for having those shared approaches. There's lots of it already, and we'll have more coming for sure in the future.
Thanks, Matthew. So, Jonathan, can I come to you to respond to Bruno?
Yeah. Very happy to, and just to add to the commentary on workforce as well. I think, as Matthew's indicated, there are a vast array of areas. Intensive care and support in each other on intensive care is another area to add to the long list of collaborative work that we're doing in South West London. We do need to acknowledge we have a worse the difficult period of time, and some of the latitude and flexibility that might have been available at the beginning of the pandemic might be less available to us at this point in time. But there is more to do. To the points that Patrick and Vasa have made, there is much more that I think we need to do to try and support our work, both the short term and further about how we build more resilience for, say, the next winter that we will have again ahead of us. So just to say, that's a really strong theme, and that's something I feel very strongly about as we develop our winter plan, which sort of links to Bruno's point. So the intention will be, when this board meets and again in a month's time, I'll share the winter plan that we've been putting together in recent weeks, and we'll have had some feedback from NHS England by the time we get to that meeting as well. I think the short answer to your question, Bruno, is I expect the challenges we've experienced to continue, and I don't see any letting up in the scale of pressure that the services are experiencing at this point in time. Given it's very unclear what will happen to COVID numbers through the winter, given we're bound to see flu and other respiratory conditions in both adults and children picking up over the period, and given the very clear expectation that we continue to treat patients in a timely way down the elective care pathway for very good reason too. So I think it's going to be a very challenging and difficult winter for us all. We're all working very hard to develop a plan that is resilient and is in a good place. And I would say, in comparison with the rest of London, our performance around urgent emergency care remains amongst the best. But there is a lot more to do, and we are planning very carefully for that. And I'm happy to, as I say, either talk outside, Bruno, or at the next board meeting to share more information about where we've got to with our winter plan, which covers both what we can do around managing demand, what we're going to do in urgent emergency care, what we're going to do elective care, and what we're going to do in staffing, amongst other things. So it's a very timely question and something that we're working really hard on.
Thank you very much for that, Jonathan. That's really very helpful.
Good. So thank you, Jonathan and Pippa, on that, and thank you everyone for your input as well. I think some really good questions and good discussion. So that was for noting. I'm going to move us straight on then to item the board showing. I think you're going to talk to this item, but this is for noting, but I think also a discussion around the risks and our satisfaction with the actions put in place.
Thanks, Andrew. Excuse me. I'll take the paper as read, but I'll just cover some. The BAF comes to the governing body twice a year, usually in September and March. So because we didn't have September, we're bringing it now. The BAF reflects two types of risks, so high scoring risks, those that score over 15, and also those that are of significance that we think we should bring to GB's attention. So we've got 4 risks on the BAF that are scoring above 15, and then 6 more that we just want to bring to your attention. So 3 risks have been added to the BAF since the last time we discussed this. So 104, which is the new risk around the re-procurement of the Connecting My Care system. 106, which is the risk of increase of non-scomal infections in providers due to the estate, and 109, which reflects the conversation that we had at the beginning of the meeting about the shortage of blood vials that we've had. We've closed one risk, which was regarding EU exit, and we've removed a further 3 risks from the BAF, but their scores have been lowered, so they remain on the corporate risk register at this point, and those were all related to the pandemic, so we're still monitoring them, but they've reduced in risk. So that's around financial instability caused by COVID. That's 064. 072, which was inadequate support for care home settings during the pandemic, and 098, which was discharge of patients, COVID positive patients, to care homes. We've got 2 risks that have increased in score, and that's 004 around the IUC contract, and 017, which Tonya touched on earlier as well, which was around the increase in demand for mental health services as we come out of the pandemic. It's probably worth also noting that obviously as we go into winter, we're also just considering the risks around the winter pressures we're facing. We're developing those for the next round of risks, the corporate risk cycle. So they will be going to the SMT in November. And that's probably all I wanted to say, Andrew, other than obviously emphasising again your comments, that welcome for comments and views on whether we've captured the right things and that we've got the risk scoring on those correct.
Thank you, Ben. I might just come to Paul, because Paul, I know that you looked at the board assurance framework at the audit committee, and I just wonder if you could summarise the conclusions you came to there.
I think, I mean, we went through them. We recognised that there'd been a lot of, I guess, tidying and some revision to the things and the scores. I mean, I think everybody really comfortable with the BAF. I think all the key risks have been covered. So I don't think there was anything really to add to that, Chair.
Okay, good. Thank you, Paul. So any other questions or comments from the board? Obviously, we're noting the risks that have been added, those that have been taken off, and we're looking at those actions that are being put in place to mitigate the risks. So what I'm really wanting to check with the board is that we're have an approach and that we're happy with the way that's being managed.
Yeah.
Yes. Good.
Yeah.
So all content with that. Excellent. Good, thank you. Thank you, Ben, for the work on that. So let's go straight on then to public questions. So I've had 2 questions submitted in advance of the meeting, and we've had during the meeting. So first written question from Molly Winfield. Will I, as an individual with an urgent care plan, still have access to it after the handover from Coordinate My Care in March? So specific question around Coordinate My Care. Tonya, do you want to answer that, because you've been helping lead this process?
So yes, individuals will still be able to access the urgent care plan after the handover from Coordinate My Care. Although we haven't specifically procured My CMC, we have ensured through the procurement scope that at a minimum London maintains the equivalent access for patients to their care plans, and this will be done via apps such as NHS apps that people are now used to using. So yeah, so that's the summary answer, Andrew.
Thank you, Tonya. Okay, the second written question, which I know it was also raised and answered at the CCAGM, but it's being asked again here. It's a question from Sue Brito. What is the criteria for London ambulance eligibility? So Jonathan, did you want to take that?
Yes, happy to, Andrew. So obviously, ambulance, what they supporting our urgent emergency care system is going to be vital over the winter period, and so keeping ambulances focused on the most in need is going to be critical. So to the question about eligibility criteria, then yes, ambulances are prioritised based on people's level of clinical need. So if you have respiratory or cardiac arrest, you can expect an ambulance to be with you within 7 minutes across the capital. But for those who have lower priority clinical need, quite rightly, you would expect it would take longer than those with the most urgent clinical need. So, and there are 4 categories and 4 criteria. I'm happy again to talk about those outside the meeting if people want to know. And then I suppose this is helpful duty to remind people about using one first rather than the 999s wherever possible through the winter period. So 111 first, both online and by phone, allows the NHS to direct patients to the most appropriate setting for them, be that in primary care, be that through a same-day emergency care route into a hospital, which might mean people can bypass A&E and get access to the specialists they need more rapidly, or be that by ambulance dispatch for those patients where that is clinically appropriate. So just a reminder to everyone on the call and everyone who listens to this subsequently that we need to keep that precious resource around ambulances for those who are most sick and most vulnerable through this winter period, and to encourage people to use 111 first wherever appropriate. So hopefully I've answered the question and also encouraged us to think about how we access the NHS over the coming months too.
Thank you, Jonathan. Helpful reminder, and I believe we'll respond in writing to those 2 questions as well. So final question that we've had from a member of the public on the renal proposal. So the question is, over 40 inpatient renal beds will be moved from Epsom and St Helier to St George's under this plan. Will the total number of beds provided at the planned acute unit at the Marsden be the same amount? So I don't think we've still got James Blythe with us, but Sarah, are you in a position to answer that question?
Yeah, well, what I would say is that absolutely, as you can see from the proposal, and this came out of the on improving healthcare together, there will be a movement of beds from Epsom and St Helier to St George's under this proposal. I wouldn't want to give you the exact amount because I think actually they're increasing the numbers of beds through this process as well, so it'll be less than the amount that that's put forward, and that makes sense. But also, we are looking at the numbers of beds required in the specialist emergency care hospital as part of the ongoing process, business case with the trust. That's impact of it, and looking at new infection prevention and control measures and things like that. So I wouldn't want to give the exact number of beds that it will impact or what that will do, but that work is ongoing, and it is part of the normal process of developing the next stage, which is the full business case. So that will, once that is complete, that obviously will be available.
Thank you, Sarah. So that concludes the questions. I haven't been notified of any other business. So what I will just say to members of the governing body is we've got some business that's confidential in nature that we'll be covering in part 2. So I'm suggesting that we reconvene at 11:40 to do our part 2 meeting. Before I finish, Dagmar, you've got your hand up.
Yeah, I'm really sorry because I didn't alert you first. Very quick question, possibly for James Murray, but us all. Is there anything we want to do comms engagement wise around COP26 is coming up? I know that James Murray is the SRO for our NHS Green Plan. If you think about future risks to health, climate change is not going to go away. And if you think again about the core benefits of interventions, what's good for the planet is good for the people, sedentary behavior, diabetes. There are so many opportunities. So I was just trying to think, as good work is happening, lots of good work as well, starting to sprout in primary care, whether that would be an opportunity we could think through to show our commitment and riding on possibly the COP26 publicity. Thank you.
Thank you, Dagmar. Good question. James, you're the executive lead for sustainability, so I shall come to you.
I am indeed. So we're pulling our plan together. It's one of the things we're actually going to take to the recovery board, and Charlotte and I and our lead Kevin have met now. So if we can pick it up offline, Dagmar, I would like to crack on with that. So Charlotte and I have had initial conversations.
Thank you very much.
Thank you. So I will draw the meeting to a close. Thank you everyone for your contributions. Thank you as well to those members of the public who have watched and for those questions. We will close now, and as I said, we'll reconvene for the part 2 meeting at 11:40. Thank you everyone.